Good evening, everyone. My name is Vicky Cowling, and I'd like to welcome over 300 participants to tonight's webinar. Thank you for joining us, and we're looking forward to a very interesting evening. As I said, my name is Vicky Cowling. I'm facilitating this evening's session, and I have a very long-standing interest in children of parents with a mental illness and their families. The last 20 years I've been involved in research and other activities relating to these children and their parents and family members. My first role is to introduce our panellists. We have 4 panellists this evening, and I'd like to start off with Associate Professor Morton Rawlins. You would have read all the biographies on the internet. Morton is a general practitioner, is located in Melbourne, has interest also in Sydney, and also has interest, I believe, Morton, in the in rural general practitioners. And I was just wondering what one of the main issues might be for rural GPs in relation to children of parents with mental illness and their families.
Probably the main one to start with is actually having access to all the right people to assist you getting the right treatment for someone like Riley.
Yes, sure, I can imagine that in some rural areas would be difficult. Thank you, Morton. Kim Foster, Associate Professor Kim Foster, works at the University of Sydney as an educator and researcher. Kim, I noticed that your primary area, or one of your primary areas of interest in research is resilience in relation to children and their families, and that you did a study tour last year. What was interesting and informative about the study tour in relation to resilience research particularly?
Oh, look, there were lots of interesting things. One of the main things that I really got going to Canada, the US and the Netherlands, that resilience is not just about the individual person, but it's about their ability to be able to access resources around them and be able to be facilitated to do that. So I think that was a really key thing that I came back with, because a lot of the work on resilience has focused on individuals rather than on their environment, including their family and health professional support. So that was a really useful sort of finding from the tour.
Thanks, Kim. Yeah, your report was very interesting. Miss Rose Cuff is an occupational therapist and has many years' experience associated with children and their parents and families. Rose, I'm just wondering, over those years, what would be some of the standout changes you've seen in relation to this group of children and their family members?
Hi, Vicky. I think probably one of the main things that comes to mind is they're actually a group that's being recognised, and the work is across many sectors now, that once children and their parenting role is...
Hi, Vicky. I think probably one of the main things that comes to mind is they're actually a group that's being recognised, and the work is across many sectors now, that once children and their parents and the parenting role is recognised, then we can actually start to talk to parents and families and children about what that's like, really. I think up until, sort of 15, 20 years ago, and you've been instrumental in that, Vicky, they were a hidden population, really, and children didn't have a voice, and it was pretty much not spoken about. So I reckon that's been the biggest change. They're more visible. There's still a long way to go, but there's sort of a lot more happening in this field than there was even in the last 5 years.
Nick, one of your enthusiasms, I noticed, is early intervention and prevention. And I just wonder if you have, over yours, especially related to this population of children, if you think we've progressed in relation to sort of valuing those approaches with these children over the last 20 years, early intervention and prevention.
Yes, Vicky, I think there's certainly some progress made. There's still a long way to go. Because,
yeah.
I guess clinically I encounter a lot of young people, by the time they're depressed or very anxious or having real problems, and some of them miss the kind of opportunities for early intervention or particularly for prevention, which they might have got if there weren't all those problems about access that what we're talking about, or some of those problems about schools, families and other agencies even kind of realising the importance of kids, as you were saying, the importance of the voice of kids really in families where parents suffer with mental illness or substance abuse problems, and that's the other big one. So there's still a lot of work to do. It's kind of finally getting there in some places, but the vast majority of kids aren't getting much access to preventive interventions. And I think that's something we can probably talk about a bit more about what that would look like if they did this evening.
Okay, thank you very much, Nick. Now, the next step is introducing you to the learning objectives, which you would have seen, but just revisiting those. At the end of the seminar, or webinar rather, we'll be able to recognise the key principles of intervention, the roles of the teacher's disciplines. So we have child psychiatry, occupational therapy, mental health nursing and research, and general practice in assessing, treating and supporting families living with parental mental illness, including identifying the risk and protective factors for the family and for each family member. We'll also be able to recognise the merits, challenges and opportunities in providing family-based collaborative care to enhance resilience in the children living with parental mental illness. So the case study tonight is about a young man called Riley, who's 13, who lives with his mum Mandy and two younger siblings. Riley is reluctant to go to school, and his mum is quite concerned about that and discusses that with her general practitioner. I guess the importance of this particular case for primary care practitioners is the opportunity it does provide for early intervention with Riley and his family, and it's also an opportunity to work with the whole family group as well. That's our way of all our introductions. The next steps in the process are that each panellist will give their perspective with a few slides to their view of how they might approach this situation and help Riley and his family. And then there'll be some exchanges of questions and answers amongst the panel and review the participants. All questions you certainly have contributed. So if we move into, I think, Morton, you're going to go first as the presenter, so we'll start with you and your slides. Thank you.
Thanks, Vicky. Thanks everybody for coming on tonight. Riley and this scenario for the family is a difficult one. One would expect that as the GP who's been seeing Riley and the family for a while, this may have happened previously in different sort of circumstances. So you may have been sort of semi-prepared for this sort of thing. But when it often does happen, it will occur just out of the blue. The first thing that the GP will be needing to do is actually do a little bit of detective work, trying to talk with Mandy about what she feels might be some of the issues that may have triggered the difficulties, and realising that Riley and Mandy are part of a unit that will need to be explored, and that will also include the younger siblings. These issues are often quite difficult to separate out and can take some time. So often in general practice, this sort of a consultation will take a little longer than a normal consultation, and sometimes it needs to occur over one or two regular sort of consultations for a general practitioner to get through some of this. And obviously part of that may be actually talking with Riley with his mum and possibly with Riley alone. We do obviously need to be well aware that Riley and his siblings are also important in Mandy's mental health, and while things are going well, that's really good for Mandy. When things are a little more difficult at home, Mandy's coping skills may be tested, and they may need to be helped. You'll obviously, as the GP, need to meet both with Riley and Mandy to get to the bottom of some of these issues. And you'd also be aware of other people who are already in the mix. So Mandy has seen a psychiatrist previously, and it may be that Riley may have come in contact with a counsellor at school. We don't know that as yet. Or perhaps his teacher may have been making some comments. So those are some of the things that you'd need to be finding out as the GP, who's actually involved, so that you can coordinate all of those things together. I always, in that sort of situation, talking with Mandy for the first time, prepare the ground for an individual session with Riley. So the next meeting that I would have with Mandy and Riley would be them coming in to see me together, and then from that particular session I would ask Riley whether he would like to talk to me by himself, and would encourage him to talk to me by himself, asking Mandy to leave the room and go out to the waiting room for 5-10 minutes. Given that I've known Riley for a little while, that usually is quite an effective way of getting some real insights into what Riley is feeling, and what might be the actual causes of this for him anyway. Within those first 1 or 2 consultations, we'd be obviously doing some mental and physical status assessments, and making sure that he hasn't got some other obvious illness. For instance, his asthma might be playing up, and he's feeling tired all the time, and he just doesn't want to tell Mandy because she would get worried. Or something as banal as that. It may also be that there may be some issues of individual maturity. He's at an age where his puberty is certainly coming on. Some boys may not be developing as quickly as others. He's going to high school. There may be some bullying, there may be some other issues that might be impacting on this that you could actually sort out perhaps with the school. The other thing that comes to my mind when I read that scenario is that it's just after Christmas, it's after the school holidays, and you just wonder whether, for instance, Riley has had contact with his biological father, and there may be some issues associated there that might need to be explored. So within all of this, the GP does need to remember that Mandy is part of this cycle of care as well as Riley. And the other thing that I would have in my mind is, are the other 2 children in any concerned? Do they have any problems as well? And I would be reassuring Mandy and Riley that I would be there to help them to reduce the risks, to explain if they wanted to talk with me about what else was going on. And I would also be encouraging them to say that there is a team approach needed. And I've always found that having an effective role with the school as well is also very, very helpful in this sort of setting. So I might just stop at that point, and really the team that I'm talking about would really depend a little on what came out in that first assessment, and also, as we mentioned before, what resources were available to me in that local area that I could call on.
Thank you, Morton, very much. Kim, would you like to proceed with your presentation?
Sure. Thanks. So just picking up what Morton was saying, and from a nursing perspective, before I speak to that, nurses are working in a number of contexts, so it would depend on whether the nurse was working as a community mental health nurse, as a nurse practitioner, working under mental health nurse incentive programs, or working in child and youth mental health. The position I took with the case study and taking the points that's already been raised is there's a couple of issues here. One is Mandy's concern and one is Riley. So I've approached this from looking in the first instance at what might be done from a nursing perspective with Riley and then move on to look at the family. So if this was referred to me as a nurse, a few things that I would want to clarify would be what Riley understood to be the issue, and that he's got a concern about him, but is that perspective as well. What is it that he actually sees as important at the moment for him, and how can we help with that? And also as part of working with him would be gaining an understanding of what he actually understood about his mother's mental health. So in terms of assessment, it would be important to look at risk and do a risk assessment with Riley, and also to do a thorough assessment in terms of, as Morton has said, around his physical health and whether there are issues happening there, what's happening with his family and in his social situation, what's happening with school because he's just started at high school, any developmental history that might be important, his mental health status and any mental health history and any other stresses that are happening. It's also important though to look at what his strengths are and his resources and to talk with him about those and to build those. And also, I guess the question here too is this normal adolescence? Is this just something that's happening at school at the moment, or is it something else? So in terms of risk and protective factors and their key aspects of resilience, I looked at the situation that he's in at the moment, and some questions that might come up are is he being bullied at school at the moment? Is the fight, for instance, around stigma to do with his mother's mental illness, or is it something else completely? Does he have carer responsibilities for his mum and his siblings? And is there an issue around the family finances and their security? He doesn't have a lot of contact with his other parents, and he does have a parent with mental illness, and these are all potential risks. But there are also a lot of strengths that he's got and protective factors. His mum is supportive and she is concerned about him, and he's got siblings and they can be protective. Does he have friendships with other peers? Does his family have good support? Do they have grandparents and people around them that can support them? What strengths does he already have that could be built upon? His mum is receiving treatment, and that's strength. And also, if there is a problem with Riley and early identification, that's also helpful. So from a broad perspective, depending on where the nurse might be actually working in, but the important thing to liaise with the other healthcare professionals, particularly with the GP and the psychiatrist, if there is a potential problem there, and to collaboratively develop a support plan in conjunction with Riley and his family, and in collaboration with other healthcare professionals, and particularly to liaise with key people, for example, social worker or the family team, if there's one available in the area, or a Cockney worker, so children of parents' mental illness worker. And also, as been mentioned, liaising with the school with permission of Riley and his mum, and a key role from a nursing perspective of coordinating care and providing referrals. And in terms of family, one of the issues that I had when I looked at the case study is I would also want to be talking with Mandy, and so it would be very appropriate to meet with Mandy and with Riley And if Mandy was comfortable with that, also perhaps meet with Alyssa and Jacob and provide them with psychoeducation that was relevant, and also to give them referrals and links to peer support programs for other groups, and encourage them to talk about mental illness, again, if Mandy was comfortable with that, and give support to Mandy in her parenting role, and also to help, if she didn't already have one, to establish a care plan for what would happen with the kids and with the family if she was unwell. So I'll hand over now, I think, to Rose.
Many thanks, Kim. Yes, so Rose, from your perspective, how was it you might?
Yeah. Hi, Vicky. Hi, everyone. I just would like to support and endorse a lot of what Morton and Kim have said, and a lot of what I'll be saying is really supporting what they've said already. But I guess the OT, what I used to call more of a holistic perspective when I was training, it's really about purpose and meaning, and just thinking about this family. I think it's looking at sort of participation in occupations for the whole family, right through to Jacob, through to Mandy. And my sense is that it's very easy for families in this family to be quite isolated, both from family, from friends, and from occupation more broadly. And Riley certainly could be at risk of not going to school and become more and more disconnected from school. So I guess it's some of those principles and approaches that I would be keeping in mind. In terms of an OT perspective or framework, some of the things that OTs routinely use is using a contextual and systemic lens. And as we've heard from Morton and also from Kim, that the importance of the whole of the person's life. Looking at developmental tasks is also very important particularly for Riley and Alyssa. We haven't heard much about Alyssa, but I think at the age of 8 is a very key developmental stage. Looking at where they have mastery and control in their lives. Gathering information from Riley in particular on the strengths and difficulties of his everyday life, and where does he see his strengths, and making sure we get good information from the other parts of their lives. In terms of areas of assessment, there's a lot of tools available for OTs to use in assessment now, and one that's quite often used is the Canadian Occupational Performance Measure, and that is a self-rating tool. So that certainly can be used for young people, and it really encourages some reflection from young people about where they feel they would like to have more engagement in their life, in different areas of their life, really elicit their strengths and where they see problems, and it's setting some goals and short-term, long-term plans for Riley and his family. So the other areas of assessment would be just through interview and individual interview, and also using other, particularly with young people, being a bit creative about how we get that information through using play or using other sort of games and activities. It doesn't require just talking at or writing down. So being a bit creative. I think for Riley, I would be very interested in really asking Riley how he sees the problem, and asking him where he feels his life might be on track, where he feels he has some control, and how things have been going prior to this presentation. What does he need to participate more fully in school and in home with his peers and friendships? How much responsibility does he feel he has with his mum and his siblings? And the age gap means that he may be quite hypervigilant around his mum and his siblings. And how does he understand his mum's overall behaviour, for example? How does he view, is he aware that she's awake at night? How does he understand her anxiety or her stress? And does he indeed worry that he's going to have these experiences the same as his mum? And who does he talk to? We all know that children and young people benefit greatly from having other adults in their lives that they can talk with. So who's in his life that he can confide in? With Mandy, I would be, again, as Kim has alluded to, developmental adolescence is a pretty challenging time. There's, in terms of a male person in Riley's life, that seems to be pretty absent. And so really reassuring her and normalising some of Riley's behaviour, and certainly again, using that systemic lens. So kind of asking her questions about what would Riley say about that if he was here would be quite useful. Asking about Alyssa, sounds like she might be also taking on the role of being a good girl, being a bit of a carer, and asking her about Alyssa's friendships and her peer networks. And again, how they understand her mental illness and her symptoms more broadly, and what resources she has. An interest checklist can be very helpful here. There isn't much in the case study about her friendships, her support, her resources, her interests. So going through those with her would be helpful, and setting some goals with her. Just briefly, Kim did a great summary of the risk, the protective and potential risk factors. So I won't go through those too much, but I think the link with the GP is a very strong factor in this case study. Her insight into Riley's difficulties as she views them, and we know that sibling relationships can indeed be, although they can be quite fraught, they can be very protective as well. And the risk factors, as I said, would be that the children can become hypervigilant. They might worry, they might catch what mum's got, not attending school, and becoming isolated. Just a few thoughts about management would be really to collaborate, as we've heard from others, with the other services and family and school being as Morton said, a key part of this collaboration for both Alyssa and for Riley. And if Jacob's attending any sort of playgroup or childcare or kinder would be very important. Supporting Mandy to talk with her school, with her children, to talk more openly about her challenges and her health issues. Kim mentions peer support programs that would be very helpful. Sometimes for teenage boys, things like taekwondo or martial arts or therapy programs, those kind of things would be very helpful. Supported playgroups. The mentoring would be good, I think. So there's a whole lot of resources out there that we'd be looking at linking this family into after some sort of family interview or meeting to help them to remain more connected with their community. That's all I wanted to say. I'll hand you back to Vicky.
Thank you very much. It's hand over to Nick Karolenko now for his presentation. Thank you.
Hello, everyone. A child psychiatrist might be involved with Riley in a number of ways. One might be just to consult with a GP, because there seems to be some very strong and effective links with his family and the family members of the GP. It sounds like there was a treating psychiatrist involved perhaps in the past, and sometimes the child psychiatrist might consult to them. And then there's this other thing about actually doing an assessment, so doing a child adolescent clinical psychiatric assessment. So it kind of depends exactly which way a child psychiatrist might be involved in this family's life. And so we talked a bit about the kind of context and which lens we're looking through. One of the things, if you're consulting, is to get a good sense of the relationship that mum has had, particularly with the GP and the psychiatrist, and how she goes with helping relationships in general. Because it sounds like she's got a particularly solid relationship with the GP from the impression we've got. And the other kind of clinical issue, and that Morton really touched upon, and we've all touched upon really, is that mum's the one coming with the worries about Riley. And we're in a position of kind of gently having to find out if Riley has got worries himself about what's going on at school. And that might have to be dealt with, somewhat sensitively. It depends if Riley's a willing participant or not, because sometimes parents are very eager for their kids to have assessment or treatment, but the kids themselves may be or may not be. And then mum thinks, the sense in this story is that mum's had a number of strengths. And currently she's got this very specific worry, amongst other worries, about whether this is her family history has taken shape in her boy. And I'd be a bit interested in knowing about the history of her illness over many years, which the GP might be more than familiar with. And because there is a story of her having had a couple of kids since her diagnosis. So I'd be interested in how she managed that, what resources she called upon, what strength she found in herself to manage that. Because one's left with the impression that she's managed at least somewhat well in the community to some extent. And then we've raised the issue about, she raised the issue about Alyssa, following the GP's kind of prompt. And it's always important in terms of the lens of assessment at what stage we're trying to get a sense of the family or the parents, and some of you speculated on whether school holidays meant there was contact with dad or stepdad, and just how that needs to be integrated in a sense with the individual assessment of Riley, and where and when that should happen. And there are no kind of distinctly correct answers to those questions. It all depends on the relationship, and finding a way to segue sometimes between individual issues of Riley, parental issues of mum, and also family issues. There might be other important other supportive and helping relationships, and that might be mum's relationship. Mum may have a relationship with school and school counsellor. The kid, Riley himself, may or may not have a relationship, and it's important to know about that because that often has an impact on kids' sense of feeling welcome, sustained, or able to maintain their spot in school. This kid's going through a transition to high school. Probably the school probably requires consent of mum, by mum, and also talking through that a bit with the kid to make sure that Riley is happy with that. And a bit of history about how he's managed at school and what that's been like over the years. The others of you have also kind of identified that Riley himself is going through a physical transition with puberty, but that also means a family transition about how mum handles the young adolescent male and what's going on with that. So mum is worried and she's there getting help, and it is reasonably early on in the cycle of what's going on. Sounds like he's been unwell for a few weeks. She voices pretty directly her worries about family history. It's common that these worries are there in parents who present with mental health problems. They don't always say them. And this is an issue about a kind of interview that has to try and bring that out. And as I said, because mum's onset of illness or diagnosis anyway seems to have been about a decade ago, there is a story that must go with Alyssa and Jacob's birth and development. And I'd be interested in hearing that or knowing something about that. Perhaps the GPs want to know most about that. And as I said, it appears she's been stable in the community and must have some community links, and we're keen to know what they are and how they're working now. So, from a clinical sense, there's an issue of Riley's probably emerging school avoidance, and it's important, as the others have already said, to understand whether that's about family factors predominantly, or whether there's bullying at school or other school factors, and what the kind of balance is between all those factors. Following an assessment, and a routine assessment involves an individual interview with Riley, an interview with mum or the parent, and a family interview. And that usually takes 2.5, 3 hours for a trial-analysis psychiatrist. If it's straightforward, it can happen more quickly, but I guess Morton was talking about the importance of time, and sometimes some of these issues take quite a while to tease out. And then the important thing, I think, in terms of clinical assessment would be to talk about the options for next steps, because depending on where you, which lens you take on, and a timeline about which issue matters first, there might be some priorities for treatment planning. Predominantly, I'd start with Riley and Mandy, and Alyssa needs to be thought of as perhaps more a medium-term aim. And again, this is really an issue about how much or what kind of proportion, for example, if there are big problems at school, they might be the ones that take a particular emphasis initially in treatment. And the other important thing with setting priorities for treatment and doing this collaboratively with Riley and Mandy is ensuring that Mandy stays in charge of this. So that one of the important things, and this varies a lot between parents that have mental illness, is that they often, their own confidence is sapped in their own skills and abilities. One option here is that Mandy is really confronting a common kind of difficulty, which is about a 13-year-old boy entering high school and having some difficulties. And this might be predominantly an adjustment issue, and Mandy might reliably, with a bit of help, work through it quite sensibly. So Mandy needs to stay in charge while kind of respecting Riley's sense of priorities. Sometimes they're vastly different, but usually there's a way of finding some way of synthesizing some common goals at least. Usually there are some disparate goals, but it's about what works together is finding what the common goals are. And then in terms of how the many aspects that Rose and Kim and to some extent Morton have talked about in terms of the range of kind of potential interventions, a decision that needs to be made about whether a case conference is required to clarify the range of potential inputs that Riley and Mandy might have and how they might be prioritised and how they work a timeline, and what the specific role, of the psychiatrist, the GP, the nurse and the OT might be.
Okay. Thank you very much, Nick, and thank you everybody for that comprehensive view and perspective of how you would approach Riley's situation. The next segment of the webinar is moving into each one of you having a chance to ask questions of the other. So I'm wondering who would like to start off. Morton, do you have any questions for either Kim, Rose or Nick that you'd like to put to them about this?
I guess probably it's a question to everybody. How do you find coordination with other professionals working the best? What works best for your particular groups?
Nick, would you like to answer that? Start with?
Yeah. Look, it's an area that has to be negotiated between, this case is kind of interesting because there is that sense of mum driving the referral. So mum's the important link, I think, depending on kind of Riley's input. And the GP seems to have had a long-term relationship. So the GP might be the person you might most want to speak to about how best to coordinate the input. But when there are a lot of people involved in providing care, at some point a case conference is pretty invaluable. Just to clarify roles, because it can be confusing for parents, it can be confusing for Riley. Usually some sort of school liaisons going to be required, but there are kind of a whole lot of, in terms of case planning, there are a whole lot of tasks that also need to go with particular roles to ensure that the things that we're all talking about actually happen, and to make sure they can be monitored, check their effect, see what bits are missing, all those kind of issues.
Yeah, I was just going to say, Vicky, that I think just to reinforce what Nick was saying about the importance of keeping Mandy as sort of parent as expert and making sure that any case conferencing or case meetings really have her involved and keep her, in some places we say that the parent or the consumer, however you want to say it, is instrumental and can help to convene those meetings. So they're very, very centre in those case conferencing.
Is there anything you'd like to add to that, Kim?
Yeah, I think the main thing to add from a nursing perspective is, depending on the nurse's role and the context they're in, they often can play quite a key role in coordinating care, and they may be, for instance, the person who actually coordinates and sets up a case conference if they're working closely with the GP and with Riley and Mandy. But it would depend on what role they were in and what context they were in.
Meaning they might be in working in inpatient unit or community mental health or community health or
yes,
possibly attached to a GP surgery, for example.
Yes.
Yeah. Okay.
I think my important question, the issue often is about planning. Planning does require a collaboration of all those people who might provide care. So, it certainly can be, at Morton's level, it might be referred to a community health nurse, as you're saying, a nurse might convene a group. But for a group to collaboratively plan, at some point we all have to be together.
Mm-hmm. Did you have any other questions, Morton, for any members of the panel?
Look, I guess one of the things just to add to that is, from a practical perspective, in coordinating these sort of things, you do need to know who the team is locally. I have a team of people that I work with quite frequently, and we have particular ways of communication. Usually it's over the telephone, but we do occasionally meet at various things. So I think one of the problems is actually knowing who you're actually dealing with, knowing their strengths, and knowing how to coordinate with them. But also one of the things that certainly helped me was people giving me ideas of things that I could be doing within the consultations that I'm having with Mandy and the family as an ongoing thing to support what they were trying to achieve rather than sort of moving in different directions. So, yeah, I think coordination and talking it can't be emphasised too much.
Yeah, I'm sure that's very true, because it's enough for parents to have to manage it all this, I guess, without having confusing messages from different practitioners.
Yeah.
Yeah.
I guess the other question that I posed perhaps to Rose to start with, it was good to hear you talk about some of the physical aspects for 13-year-old boys in their therapies. Are there particular, for want of a better term, therapeutic guidelines for physical therapy in this sort of situation, do you think?
Well, not so much guidelines, but I think thinking outside the square around, what's going to be helpful for Riley, given that he's a boy of 14, he's not going to want to sit and talk for now necessarily. So things like, I think I mentioned when I talked, there are some examples of martial arts as therapy programs which are particularly helpful for boys. Well, there's some for boys and girls that are run using people with experience in martial arts, but doing it in partnership with perhaps a family service or a community health centre or a community mental health centre where you've got the sort of therapeutic input as well as the martial arts. There's other programs, I forgot what it's called, using physical activity called rock, water, something, not rock, paper, scissors, but something like that where there's a whole lot of physical activity that's particularly helpful for teenage boys. Peaceful Worries, there's a range of different programs that are available, and I think they're really great to both express physical energy but also to harness it in a more positive and creative way. And it's a great peer support network where they meet other perhaps young people with similar issues and challenges. Sometimes just engaging with, I think Kim talked about the importance of engaging with young people, finding out what they enjoy and kind of trying to meet them at their level. So, using a ball or using drawing, painting, whatever it is they feel like doing is very important. Does that answer that question?
Yes, thank
you. Look, the other thing I would just add about planning and integrating supportive care, which is something very specific from the child psychiatric perspective, about saying, often it's about I'm here to provide an opinion, and care coordination and the core role that looking after you will remain with your GP or your mental health nurse or whatever. So, and then part of the collaborative kind of planning with the family in terms of the child psychiatric assessment and consulting is also about exactly what you're saying, Morton. What advice might you give to the GP and the other members of the team about aspects of the family or Riley's care? It's important to make that really clear, I think, to parents particularly when you see them, that your role is to try and add value to the team that's looking after you well.
Okay, thank you all for those questions and answers. Rose, any particular questions you have for any members of the panel?
I guess I was particularly interested in asking Morton about how, as a GP, it's fantastic to hear you, knowing that you talk about a sort of family-focused approach and that you would see the family and how you incorporate that into your GP practice, holding, I guess the more than one person in the room kind of approach in such a limited time frame. How do you do that?
Lots of practice. Look, it can be really difficult sometimes. One thing is that you do need to be aware that sometimes you are going to have a difficult consultation, which is going to take more time, and you need to try and factor that in. Occasionally, if it's something really acute and for instance, if Mandy was saying to me she was extremely worried and, it was really affecting her and she was getting down, and I knew that that was a warning sign, and this was mid-morning, I'd be perhaps saying to Mandy, okay, well, look, let's organise a time at lunchtime. Can you come back? Let's spend a bit more time. Because I also realised that I can't spend forever with her and leave my waiting room just filled up. So there are ways of fitting it into your practice if you have worked that up beforehand. I think it's also good if you've got a good team around you to be able to then sort of ring someone and say, look, there's a real problem here, what do you suggest we do? So apart from that, just being able to say to Mandy, okay, well, let's organise to do this, this is the plan, and I can get back to you. Nothing's perfect, but you have to do what you can. It can be very difficult in rural settings where there may not be very much support for you, but you just have to give the time as much as you can. And usually patients accept that if you do that for others, that you do it for them as well. So as long as it's not happening all the time, you're okay.
I guess, Vicky, I just wanted to make another quick comment about this in response to what Morton said, and I think I mentioned it before, that for professionals where seeing families can be quite difficult, problematic because of time or because of distance, the notion of the sort of circular questioning and having that systemic lens is a very powerful way of having the family in the room, in a sense, when you don't always have the time to do that. So really inviting comments about the person's view of how that family member might view the problem or the situation. Just, that kind of systemic lens is a great way of doing things with a family focus.
Oh, yes. Rose, did you have questions for others on the panel for Nick?
It's to people. It's Rosie asking. I was going to ask Nick. Nick, as a psychiatrist, I'm just wondering how, in your experience, how routinely do you think that particularly adult psychiatrists are taking into account the impact of things like medication and symptoms and behaviours on particularly parenting roles and responsibilities, and the impact of symptoms and illness on children and family, rather than taking the sort of the individual approach?
Yeah, look, I think some psychiatrists have disagreed with thinking about the impact of illness and symptoms. I'm just having some problems with sound, but I'll just answer your question. I think that sometimes psychiatrists have some problems with thinking, especially parenting, because adult psychiatrists aren't much attuned to their patients' parenting. However, there are a number of exceptions to that. And there are some adult psychiatrists and some parents who tell you how carefully their psychiatrists have actually thought about their parenting issues with them. And the College of Psychiatrists has certainly encouraged its practitioners across those working in adult settings, child settings, forensic settings, whatever, to consider the children of the parents that they see. And so again, we're probably best to say it's an emerging skill amongst most psychiatrists, although the child psychiatrists have probably got the inside running on it, I hope.
You're a pioneer.
So there's a kind of a second part to your question, I think. Was there, Rose?
Well, I guess the second part was really, it's hard to sort of broadly answer this, but your sense of how the understanding of the impact of parents with medication, but also the sort of behaviours of a particular parent or family member on children, and the psychiatrist's kind of capacity really to sort of manage that or deal with that when they see clients? Really
look, I think that
handle that?
I mean, I do see a number of patients, particularly in the rural setting, who are over-medicated in terms of their capacity to care for their kids. And it's an issue that sometimes needs to be pretty carefully considered. Once you're talking to parents about their kids, they're very straightforward about telling you how much their over-sedation, for example, gets in the way of parenting. And providing you are having a clinical discussion that focuses on their parenting functions and the things they do as a parent, those issues become apparent very quickly. It's the issue of just making sure they get raised. Yeah, and parents too, sometimes because of the severity, acuity, intensity of an acute situation, aren't thinking about parenting up front. It's obviously much more of an issue that occurs to them as soon as they get home. But having said that, depending on where they are, there isn't a lot of encouragement from the context that they're in often acutely to think about kids or kids' issues or family issues. But in reality, they're all, if you're a parent, you're thinking about your kids, no matter how sick you are, really. And as you know, some of the inpatient settings are trying to think through the issues about having kids and families access inpatient settings, see their parents when they're there, and all those sorts of issues.
Okay, thank you. Questions for anyone else on you, Rose?
No, I'll hand over to somebody else now. That's okay.
Okay, thank you. Kim, do you have any questions for any panel members?
Well, actually, yeah, a couple of things. And one thing before I did ask a question is about mental health nurses and about their background in terms of family-focused care, because I think that's an important thing to address. I think that can vary a lot for nurses, and some nurses have a lot of experience and have had that. One of the things, and I have noticed people have been asking questions about COPMI, and I did mention COPMI in my presentation, but the National COPMI Initiative, which stands for Children of Parents with Mental Illness, is online and has an enormous amount of resources. And one of the things that's been developed that nurses and other allied health professionals can do to upskill themselves if they don't feel comfortable with family-focused care is keeping families and children in mind. It's an online resource that really gives a great background and gives a lot of information about how to work with families and a lot of detail. So that can be something for nurses, for example, that they can do if they don't feel as confident in that area. So that was that. But I've just got a question, I guess, initially for Rose. Just looking at particular approaches that you might take if you're working with the family as a whole. Are there any particular family-based approaches that you might suggest as being particularly helpful when working with the whole family, Rose?
Well, I think sometimes therapies like narrative therapies or therapies that have a sort of psychoeducation approach, because I think sometimes when families present like this, there's a distinct lack of, there can be a lack of communication and relationship between parents and children and family members. So, and narrative therapies are very helpful in sort of looking at telling stories, but also trying to reauthor the family story. So, I think I'm based in a family therapy organisation called the Delivery Centre in Victoria, and a lot of the work that's done here is using different family therapy approaches. And we see families here quite regularly where there's present mental illness. And they're developing family meetings where we incorporate psychoeducation with the whole family, particularly focusing on children and supporting parents to actually have these conversations with their child or children and other family members. And it's much more respectful, I think, to the parents. Thinking about what Nick has said in his presentations about the importance of keeping the parenting role highly valued and the parent as I said, the expert and central. Having the whole family hearing what's being spoken about can reduce the potential for blame and shame for parent, like I've failed as a parent and my kids are like this because I've got bipolar or whatever. So the family approaches are very powerful. Yeah.
I'd probably have a question, I guess, for Morton around getting back to adolescence and Riley, for example. Are there any particular health issues, physical health issues that you might want to explore and exclude if you were looking at his health and well-being?
Right. That's actually a really broad,
I know.
answer. To some degree, it's guided a little by your knowledge of Riley in the past. Certainly, if Riley had some chronic illnesses from previously that might be flared up at the moment, and that could be something like asthma I mentioned before, but equally something like atopic eczema that may not be obvious as you walk through the door, but he may have a bad exacerbation on his abdomen that if he takes his shirt off at school, it might be a problem for him, something like that. So you'd focus on the things that you knew he may well have, and then from there you would take the tack of trying to work out what else may be concerning him. As we've said, he's in that stage of pubertal growth, which may be mismatched to his peers, and that may be a sense of concern. Depending on the size of the high school, it may or may not be very supportive of the Year 7s and Year 8s, and that can it may also be the first time that he's actually having really close contact with girls, for instance, and he may be having some relationship issues with people that he doesn't know. He may be the only child from his small small primary school in the country, for instance, going to that particular school in high school. So he may have to be just developing a whole new set of friends, which you may have difficulty with. The other thing that I've had with some children is change of teacher. They have really bonded with a particular teacher who has been transferred out or left, and they're very much left adrift, and that can be a major problem for some children. It may also be that he's picking up on some cues from Mandy at home. She may not be quite coping as well as we might think from her initial presentation to us, and there may be some issues. She may not be sleeping well, or there may be other problems. So he can also be a barometer to how Mandy is going and give us some insights there. Having known them for a while, you would hope that you would be able to get them to open up to you, and that can happen very quickly if you know the family over years. It doesn't take more than a couple of minutes for people to feel comfortable enough to say, well, the real problem is that Mum's just not understanding. She's up all hours. She keeps me awake, so I'm always tired. Those sort of things. Again, you need to take those with a grain of salt so that you don't go off on a tangent. But it's just added information that you need to deal with.
Thanks. Nick, would you like to pose any questions to any members of our panel?
Sure. I'm more just sort of touching upon
Mandy's functioning, because Mandy has a kind of, it's a relapsing illness, with, cycles of being well and unwell. It's possible that the story reflects the start with insomnia of mum experiencing a new wave of illness. So that's important for a GP and families involved to assess. And with families and parents who are involved with GPs over a long time, and often they have quite a story. More than you were talking about early warning signs, when they've got a sort of dialogue about how they recognise perhaps early on in an illness what their most frequent kind of presenting complaints are. And sometimes parents have a pretty clear kind of plan outlined about if they think it's possible that they might be getting unwell, who's the most trusted member of their kind of social network that they want involved, how they want their kids managed, if they're getting unwell, if they're getting sick or hospital comes up. So sometimes these things are kind of well planned in advance. And I've certainly found, working most commonly with mums, who have postnatal kind of mental health problems, often by the time they've had 3 kids, they've got pinned down a pretty neat system, of management, with a good GP, about how they're going to recognise if things are going off the rails, how it's going to be managed, and it gives them a lot more control about how they want their illness and the kind of consequences of their illness being their parenting, how they want that managed. So that kind of thing usually happens over time in general practice, and that probably is a really good role for kind of thinking about the future, particularly the mental health nurse's role. The other thing, I guess we haven't talked about much, but it was flagged at some point, is whether Riley's beginning to have a mood problem himself. Mum's fundamental worry. Is he starting, some emerging depression? Is this kind of separation anxiety where he's concerned about mum's health and well-being? So there are kind of some very straightforward clinical issues to try and assess here. And I must say, it's in the country that I sometimes get a lot of urgency around referrals like this involving parents who are desperately concerned about whether their kid's mood disorder is the beginning of the bipolar illness that they too have suffered. And this can sometimes present as a very acute worry that people don't quite know how to address. It kind of comes straight through to the child psychiatrist. And it has to sometimes be teased out, because often early on in the course you don't know. And of course this kid might well be having, a mild depression or something in the context of his family circumstances that is not the beginning of a bipolar illness. But they're all clinical issues that actually have to be sorted out and have to be carefully kind of discussed with mum because of her fears and worries about it. The other thing I was just going to mention, Kim was talking a little bit about resources. There is an excellent family-focused DVD which comes out of the Copley Project, which is available for free. There are 50,000 of them in a partnership with Beyond Blue, which is a really nice DVD showing parents how they might address the kind of issues of their mental illness with their family and with their kids. And there's also a part of that which is about information solely for kids, about trying to think through what it might mean if mum or dad have mental health problems, and what does it mean for their lives, and what does it mean for their, their kind of well-being. Because one of the features, I guess, that encourage that develop same kids' resilience in this context is their understanding of their parents' illness and getting a sense that it's not all their fault. There are a number of other issues as well. Cool. So I just wanted to talk about those issues, the clinical issues that, the context might be somewhat different. It might be that, in fact, Riley is developing his first sign of a mood disorder, and that would be a far more involved kind of clinical exercise, but doesn't exclude the importance of then coming back to the family work. Because I guess we've talked about Alyssa and Jacob, and certainly some of your questions about parenting and parents with mental health problems, thinking about parenting, they're a particular issue that's getting a bit more addressed, I think, in adolescents and children, but not so well addressed for younger children and toddlers. So that's probably an area where we haven't made a whole lot of progress over the last several years. And I think thinking through Jacob's needs would be the kind of a priority that needs to come towards the end of thinking through the kind of family issues, depending on how they go with Mandy.
Okay, thank you, Nick. And I think talking about the family focus DVD is worthwhile, and the other one that you mentioned, keeping families and children in mind. I just noticed that Mandy, who has come to the doctor from the questions on the screen, Mandy's come to the doctor, someone pointed out, what if Riley doesn't want to be involved at all? How might that be managed if Riley doesn't want to engage? And how can we deal with that? Anyone like to have any ideas with that?
Well, it's not rare.
No.
So here's a common difficulty. And I think that's what comes back to this thing about Mandy's the parent and Mandy's in charge.
Yes.
It still is a problem. How does she want to address it?
Yeah.
And how does she want to come at it? At the possible, does she talk to school? There's a whole lot of other parts of her network that may play a role, including herself, even if Riley isn't an active player just yet. Obviously your aim would be to try and get him to be an active player down the track, but it might not start off that way.
Mm. And that raises an issue we hadn't really had time to address, but working with the school, and there were a couple of questions that came through when people registered in relation to school. One was how to help the school understand what's happening for a parent without invading the parent's privacy. How do we achieve that? One immediate thought that comes to mind is providing education for all of the school staff, so it's not focusing on any individual parent, and then information about the impact on parenting. Another issue that came through on the questions that registrants put forward was in relation to child. My take on that would be that the responsibility that's determined by state regulations and laws and requirements in each state and territory of Australia and one's own discipline. They're not in private practice or in public practice or non-government agencies. One thinks about that.
I just want to get back to it's Rose here, your comment, Vicky, or inviting us to think about if Riley isn't, as a 14-year-old boy isn't wanting to enter into sort of counselling or any kind of going to a service, is really, I think, as Nick said, is really working and talking with Mandy about that relationship and giving her some assistance and support to really begin to talk with Riley more about how he's going, and inviting her some sort of practicing the kind of conversation she might want to have with him. And that's where the SDQ can be quite helpful, the Strengths and Difficulties Questionnaire, which is routinely used, and many people will know of it and will have used it with Mandy, which will really invite her to think about both Riley's strengths and difficulties, to have some engaging conversation with him, which may then naturally lead to him being more perhaps ready to address what's happening at school, what's happening with himself, with his own thoughts and feelings. So I think often the key is actually through the parent-child relationship, rather than always shining a light on particularly a teenage boy.
Yes. We have just about 4.5 minutes left. Are there any final comments from any members of the panel, just to sum up very, very briefly what we've been discussing this evening?
Yeah, it's Kim here, and I think just getting back to things we've raised before, a lot of people on the chat line have been asking about resources, and as we've said before, and I'm sure will come after the presentation, the National Copmi Initiative website really has all the resources that we've been talking about, including peer support programs across different states, professional development programs, etc. So it's a fantastic resource wherever you are to follow up on the research. I noticed people were asking about research. There has been a lot of research about the effectiveness of this type of support, and it can actually be preventative for children, so it does work. So that would be a good place to sort of go to if you've got further questions around that.
Definitely, yes. Thanks,
They're just backing up on that, Kim, the COPMI website, this is a big plug for the COPMI website, the COPMI Gems, which is Gateways to Evidence That Matters, they're on the website, are great little nuggets nuggets of research and evidence-based and very specific around what helps children and families. So, for example, we know that it's a protective factor, children understanding what's happening with their parents and how that happens, supporting parents or health professionals to do that. So the gems are really good as a way for people listening tonight to go and start looking at some of the research and the evidence base around this work.
Thanks, Rose. Martin, do you have any final observations?
Look, just to say that often the GP does have a lot of insights into the family as a whole from previous experience, and certainly I as a GP would be very welcoming of somebody ringing me if they were seeing Riley or Mandy to ask about other things that may be impacting that are not coming out. And that doesn't take long to do and can be very helpful. GPs are usually about trying to keep the family functioning and treating the family as a whole.
Thank you. I just noticed a question about the SDQ that Rose referred to. It's actually available on the internet. Just type SDQ or Strengths and Difficulties Questionnaire into Google. Jeff, do you have any final observations?
Yes. Look, a few things. People have talked a bit about family therapy, and certainly as well on the website there's actually a training in preventive intervention, in family-focused training. You can have a look at clinicians working with two families and go through the training process, and you can see just what family therapy looks like over a kind of 7-session intervention. And that's the kind of intervention that we're talking about that have an evidence base for preventing depression in offspring. And there's some recent synthesis of evidence that suggests with these preventive interventions about 40% of the prevalence of depression in adolescents and children can be prevented. That is, new cases won't occur, providing these kind of kids and families get access to these preventive interventions.
Okay, I'll have to stop you there. We're about to run out of time, so thank you for that. Just to sum up briefly, I mean, it's a family-focused approach that we need to take, a collaborative approach, networking, coordination, ensuring that parents stay in, have the authority within their own family to be a parent, hearing the voices of children and young people, and giving them an opportunity to make for their observations and experiences and ideas about what is happening to themselves and their family and their parents. So I'd just like to thank everybody for participating, and good evening to you all. Thank you.